Hi everyone, my name is Radha. I'm one of the education and training pharmacists and I'll be doing today's session. I just wanted to know if I did send out the pre-workshop questions. Did everyone receive those and did anyone do complete them? Type in the chat box or just turn your microphone on. Okay, so didn't receive any. Okay. Did Katie send you the link for this? Was it Katie Power? Yeah, okay. So she should have sent it to you. I'm not sure why she didn't. She might have been, I don't know, maybe sick or on leave. So I'll go through the answers even though you haven't done them, but it's for your learning anyway. I'm going to make a start. Anyone who comes on will just have to come on afterwards. Okay. So today's session is on good prescribing and controlled drugs. So like I said, my name's Radha and I'm part of the education and training team. So I'm one of the pharmacists and I normally do teaching regarding prescribing to fifth year and third year medical students and junior doctors within Lewisham and Greenwich. So today's session was meant to go through the pre-work answers. We'll still go through them. And even if you haven't been given them, hopefully when she comes back, she'll be able to send them through and it will all make sense. Go through the aims and objectives of today, look at drug charts. So I'm aware that Lewisham and Greenwich use the electronic prescribing system. However, this session is more about the good medical prescribing basics. And you'll always need to know how to prescribe on a paper drug chart. So that's what I'll be going through. Principles of good prescribing, prescribing controlled drugs, and some group case studies. Again, these should have been sent to you. So we'll work through them together. Yeah. So the first question that you should have got in your pre-work was to go through penicillin allergies. So it was just to say whether the medication can be given safely if the patient has a penicillin allergy, or it should be avoided or given with caution. So all medications that contain penicillin, if you've got a penicillin allergy, should be avoided. So these include flucloxacillin, amoxicillin, tazocin. Does anyone know what kind of penicillin is within tazocin? Anyone? Okay, so within tazocin, there's something called piperacillin. So piperacillin is obviously a penicillin and you can't give it in allergy. Does anyone know why you would give cefuroxime and meropenem with caution? No? Okay, so cefuroxime and meropenem are both given with caution because there's a slight cross-reactivity. So it's up to 6.5% of people who have a penicillin allergy can also be allergic to cefuroxime and meropenem, which is why if the benefit of the treatment outweighs the risk, then we give it, but it's always on a patient-patient basis. What was that question? Then we had a question about prescribing an amiodarone infusion. So you would use glucose 5%, special monitoring would be ECG, and then you'd have to decide the duration, which is 20 to 120 minutes. And then you would have to see whether the infusion fluid was compatible. So if glucose or dextrose are compatible with amiodarone, but sodium chloride is not compatible. Does anyone know where to look up this information? Like, how would you know what's compatible? Yeah, exactly. So in the BNF, whereabouts in the BNF? Interactions. No, not quite interactions. Let me share my screen and I can show you where it is. Show you. So if you just go into the BNF, then you type in. And then it should be under directions for administration. So it says here for intravenous use, manufacturer advises giving continuously or intermittently in glucose 5%. Suggested infusion volume is 250 ml over 20 to 120 minutes. So it would always say it there in directions for administration. And that's where you would check to see the compatibility. You would always give what it says in the BNF, or there's something else called Medusa that you can also look up. That's what you'd give. So that's how you'd prescribe the amiodarone infusion. Then we had a controlled drug prescription. So for a controlled drug prescription, it was basically giving the details and you had to write it up. So you would always have all patient details, so name, date of birth, hospital number, and address, and then the doctor's name. Then you would write out the drug, so the generic name, which is morphine sulfate, then the formulation, which is tablets, the strength, which is 10 milligrams, and then you'd have the directions. So they have to be exact directions. So take one tablet every 4 hours, and then you have to write out the quantity in words and figures. So they've written 840 milligrams, and then they've written it in words and figures, so 840. So you can either write it like this, 840, or you could say, I want to give 84 times 10 milligram tablets, and then you could put 84 in words and figures and the 10 milligrams in words and figures. Either one is acceptable. And I guess writing 84 times 10 milligram tablets is just a bit easier to work out what they want as opposed to writing 840 in full. So that is how you would do the prescription. So then I had a question on renal impairment and whether any of these drugs, the dose needs to be adjusted or if you can't give it in renal impairment. So again, you'd look in the BNF in the renal impairment guide, or if you can't find it there, then you would ask your ward pharmacist. So erythromycin, metronidazole, and fluoxetine, you don't need to change, but with digoxin and vancomycin, you might have to adjust the dose depending on how poor their renal function is. And then the last question was about interactions with warfarin. So here it states you can look at the interactions in BNF Appendix 1. So if warfarin interacts with amiodarone, it increases the effect of warfarin, which would leave you susceptible for an increased bleeding risk. Rifampicin decreases the effect of warfarin, so it would be the opposite. You would have greater risk of clotting. Blenroflumethiazide doesn't have any interaction, and ciprofloxacin and diclofenac both increase the effect of warfarin. So it's really important you know where to look for those interactions, and that's in the BNF. You can either use the app or the book. If you're using the book, then it's in Appendix 1. Then this question was basically to prescribe regular medication. So you had your aspirin dispersible, right at the dose, the route, and then the timing. Digoxin 62.5 micrograms and Senna 15 milligrams. So I just want to highlight the digoxin 62.5 micrograms, where micrograms is written in full. Go to below. So you can't ever put 0.625 milligrams or 62.5 mcg. It always has to be in the correct units, so fully in micrograms. And on the drug chart was also in the question, it was to also prescribe the simvastatin. However, this patient's also on clarithromycin, so you would hold the simvastatin because of the interaction between simvastatin and clarithromycin. So this is the other bit of the question, the answer. So you have the antibiotics prescribed, amoxicillin, so 1 gram 3 times a day IV. Always make sure to put in your indication and where you've got that information from. So if it was a guideline or if it was micro advised. And the clarithromycin, again, the dose, the frequency, it's being given orally when we're going to review all what the duration is and what it's being used for. So those were all of the pre-questions. Does anyone have any questions about that? I know it's kind of difficult because you didn't have the questions with you, but I'll email Katie again and ask her to send it out. I'll move on to the next bit. So today is just talking about good medical prescribing. So prescribing on medications is one of the most common interventions that you will do as doctors. And in the UK, on average, about 7,000 medication doses are given out per day. So there's a lot of room for error, and prescribing errors are common and are highest among junior doctors. And this is why we do this teaching, to make you aware of the common pitfalls that occur. And if you're more aware of them, then they're less likely to occur. So good training is therefore vital in ensuring safety and effectiveness of prescriptions. So principles, so always use approved and reliable sources if you're in doubt. Talk to your pharmacist, otherwise use the BNF, the BNFC, trust guidelines, policies, the IV guide. So the IV guide is something called Medusa that you can use, which is found on our intranet homepage, and it will tell you a guide for any drug that is to be given administered IV and the instructions on how to give it. So what to give it in, the diluent, how to make it up, the rate it should be given at, etc. And if you're still unsure and you've checked these resources, then you can always contact the pharmacist. So then if you're writing out a drug chart, it's really important that you write in block capitals to make it clear what is being written, and you sign and date it. And if you have a bleep number, you put that down, because we need to know if there's something wrong with it, or if there's something we want to change, then we need to be able to contact you, because you may not always be on the ward. So this is an example of how not to write it. I still have no idea what this drug is. And because sometimes people are in a rush, these errors can occur, and then it can lead to a patient getting the wrong medication. So you have other principles of good prescribing. So at a minimum, these are the things that should be included on your prescription. So the drug name, most drugs should be prescribed by their generic name. So for example, here now we no longer use Clexane. We use Inhixa, which is enoxaparin, and that's again a prime example of why we don't prescribe a brand name, because the type of drug and the brand that we're getting is always changing. And if you prescribe by brand, then the patient might miss a dose. However, there are some cases where we prescribe by brand, and these are occasional, and it should state clearly in the BNF if those drugs are prescribed by brand. Some of these include theophylline, antiepileptics, and lithium. So like I said before about the micrograms, never include trailing zeros, so 1.0 or 0.06. Like always do it to the best units and write the units out in full, don't abbreviate them. Things like micrograms, nanograms, and units. And do not prescribe mils for liquid. So if a liquid is like 10 milligrams in 5 mil, always put the strength of the drug. The strength of the drug in the dose, not the amount of mils, because sometimes there could be multiple bottles lying around and they can have different strengths, and therefore if you write it in mils, the two bottles might have different strengths, and then the nurse might be giving the wrong dose. Always ensure that a route is stated. So if it's oral, if it's inhalation, if it's IV, if it's subcutaneous, etc. You have the frequency, so ensure the time is circled or the frequency is stated on the drug chart, and make sure that they're sensible and appropriate. You're not waking patients up in the middle of the night just to give like a Senna tablet. They have to be appropriately timed. And block out, cross through relevant parts of the drug chart if it's only to be given, the drug is only given like once a week, for instance, methotrexate, or on alternate days, etc. So again, the abbreviations, you should not be abbreviating mcg, nanograms, and units. They should always be written out in full, and this is because there have been many incidents where, for instance, the U, which is abbreviated for unit, can come across as being the number 0, and instead of 6 units being given, 60 units were given instead, and obviously that's a massive overdose. Micrograms, again, it can lead to ambiguity, and the mcg can look like mg, and then you're giving like a massive dose, which is not good. So then we have some principles of good prescribing. So allergies, we always must make sure that when you first meet a patient for the first time, you ensure that you always ask what their allergy status is. And if they do have an allergy, document it and document the reaction to it. Sometimes it can just be a side effect of the drug and they just don't have it because of that. But we need to sort of draw the line between what side effect is and if it's an actual adverse drug reaction. because sometimes the benefit will outweigh the risk. Sometimes with antibiotics, a lot of the time you get diarrhea, nausea, and vomiting, and patients don't realize lots of side effects and it's not an allergic reaction. So always document the drug name, nature of reaction, source of information, and sign and date it. So then we have the Trust Medicines policy. And the Trust Medicines policy is quite a long document, but it details everything that can be prescribed, by who, and who should oversee it. It has a bit about the controlled drugs. It has a bit about the normal medications, high-risk medications such as warfarin, amiodarone, the cytotoxics, etc. It states in there what junior doctors can prescribe and what they can't prescribe. So junior doctors aren't permitted to prescribe cytotoxics or immunosuppressants such as azathioprine, hydroxycarbamide, methotrexate, mycophenolate. And even if it's like a home medication and you're just transcribing it onto the drug chart, it has to be a more senior doctor that does so. So then we have principles of prescribing controlled drugs. As for any medication, you must state the drug name, the dose, route, and the frequency. You have to put in the formulation type, so whether it's modified release versus immediate release, because this obviously makes a massive difference. For instance, if it's a pain medication and it's a modified release preparation, state the total quantity to be supplied in words and figures. So this is the biggest difference with controlled drug prescriptions. So 60 20 milligram modified release capsules would have to be written in words and figures. So the 60 bit has to be written in words and figures because that's the total quantity. You shouldn't really put one box of 20 milligram capsules, because one box could be 60 tablets or one box could be 100 tablets. It's not really said, so this is what I mean. Morphine sulfate extended release, morphine sulfate extended release, they're both the same drug, but one box has 30 capsules and the other box has 100 capsules. And if you just put in one box, there could be a massive variation. So it's really important to be specific about the number you want to give. And even with the electronic prescribing system, we need a physical hand-signed copy to be presented to the pharmacy in order to get the medication dispensed. So in our Lewisham and Greenwich drug charts, as all drug charts in all hospitals, there's a part where you have to complete the patient's details. So this normally compromises of the hospital number, patient name, surname, NHS number, hospital number, and date of birth, and an allergy section. So what the allergy is and the reaction to it. Then you normally have a stat doses section where you would put, write the stat dose or once only doses, and ensure you state the date and time to be given. So even though you've written it up, you must always inform the nurse that you've written up a stat dose. And sometimes it's a medication that they don't have on the ward, so you also have to inform the pharmacist that this medication is to be given. Then on our specific drug charts, you have a bit just for antibiotics. So it's antimicrobial prescriptions, and this should include the drug name, the dose, the frequency, the route, and you must sign and date it. You also must put a review or stop date and recommended durations. In Trust antimicrobial guidelines are normally 48 hours. So you would do a review after 2 days, so 48 hours, and then if you want to continue, a review at 5 days, then a review at 7 days, and then a review at 10 days, and hopefully by this time you have a duration or you've contacted the microbiology to seek out their advice on the duration. Then we have another section for therapeutic drug monitoring. So therapeutic drug monitoring includes gentamicin, vancomycin, amikacin, and this is just a bit more detailed because it goes into detail about taking levels. Just expanded it. So you have, this is for gent and amikacin. So you have the dates, and then you have when they require a level, so you can tick across it, and then you write when the level is due, and then you can write when the level was actually taken, and then the result, and then what the nurse should do. Should they give the dose? Should they hold the dose? What should they do? So that's really like a little nice way of prompting them about levels, because a lot of the time levels aren't taken, or they're not taken at the right time. And so by putting it all down neatly, we can see whether they need it. So all of this information is usually in the antimicrobial guide, micro guide. And so I would suggest if you don't have your micro guide, you should download the app. It's really useful because it will tell you more about specific antibiotics, the indications, durations, what it covers, and what to do if you've got like a penicillin allergy, etc. Goes into detail about like if you've got an obese patient, how you would measure based on adjusted body weight, things like that. And it tells you all about the levels and therapeutic drug monitoring. So I would suggest getting micro guide. Then on our drug charts, again, we have the warfarin prescribing. So warfarin is prescribed in this box here. So you would have the date, the drug, the target INR range, and the duration, and then the indication. So even though we have electronic prescribing, all of these things are still required on the electronic system. And then if it's a newly prescribed warfarin, then we would prescribe day by day and base it on the INR. So then next to it, we just have our warfarin guidelines. And this is really important if you're loading a patient on warfarin, and depending on what you're loading the patient on. So if the patient is over 75 or weight less than 60 kilos or has any of these comorbidities, then we would start with 3 milligram daily dosing regime and then base it on INR, or sometimes we would go with 5 milligrams, and then you can also do fast loading for under 65-year-olds, which starts with 10 milligrams. But this is all found in the guideline, and then we would use that to base our warfarin dosing. So warfarin in our trust is always given at 6 p.m. and make sure that it has been prescribed in order to give the dose on time. And the main things to look out for warfarin is the target INR and range, the duration of therapy, and the indication. So we have another section, which is on VTE prophylaxis. So our VTE prophylaxis is usually enoxaparin, the low molecular weight heparin of choice. And then we have the dosing up here. So you would fill out your thrombosis risk and bleeding risk, so the risk assessment, and then decide whether they need a low molecular weight heparin. And then here is the dosing for prophylactic doses. So under 50 kilos is 20 milligrams, 50 to 99 is 40 milligrams, 100 to 150 is 40 BD, and then anything greater is 60 BD. And if you've got renal impairment, under 30 mils per minute creatinine clearance, then you should opt to go with heparin. So for regular medications, this is how it would look on the drug chart. So you have your drug name, the dose, the route, any additional information. So bisoprolol is for the heart, and it should be omitted if your heart rate is less than 60 beats per minute. And this is where it would be written. here, and then make sure you always sign and date it and include your beep number, and also the frequency must be circled. That's how we prescribe regular drugs. And then it's slightly different if the drug is only meant to be given once a week. So alendronic acid 70 milligrams is only to be prescribed on Mondays here. And so the way we write it out on the drug chart is the time it has to be given. So it's normally given at 6 a.m. And then we cross out all the other days apart from the Monday dose. So where that box is left uncrossed is where the nurses can sign it to show that it's been administered. And that's the same for short courses. So prednisolone is only to be given for 5 days. So the valid period is 5 days. And so we've left out 5 boxes, 1, 2, 3, 4, 5, and then we've crossed off everything else because we want to stop it off. On our Lewisham and Greenwich drug chart, we have the insulin prescribing like this. So you would have breakfast, lunch, and then we have a dinner slot. So you would write the insulin name, and this is always done by brand name and the device name. So if it's a Flex pen, or if it's like an ActraRapid cartridge, or if it's a Quick Pen, whatever it is, you always have to state the brand and the device. Then you put the dose in units, and then you sign it. But because in hospital we quite frequently alter the dose, if we alter the dose but we keep the brand and the device the same, then you can just cross that bit out and then re-prescribe here. And then the same again if you want to cross that out and then re-prescribe here. So make sure that you've always got units written in full without no abbreviations of U or UI after the dose. On the drug chart, it's always just a number and then units written in full. Then lastly, we have as required medication. And so as required medication has the drug, the dose, and you have to put the maximum frequency. So if it's prescribed on the regular side and the as required side, you have to put how many doses as a maximum you want to give in a 24-hour period, making sure that they don't overdose. Then you would put the route, the start date, signature, and any other instructions, so any monitoring or anything like that. So for instance, if you had Zopiclone in the when required side, some of the nurses might not know what Zopiclone is used for. So in the other instructions, you would put for insomnia to aid sleep, and then they can decide which dose to give and if it's needed. So I would always put the indication in as required so that the nurses don't get confused. Frequency. So for example, paracetamol 1 gram 4 times a day, you should put 4 grams in 24 hours is the maximum frequency. So now I've got a few prescribing cases. So you guys are going to have to look at it and then tell me what the mistake is if you can spot it. So either put your microphone on, or you can put it in the chat box what you think the mistakes are. So a patient is admitted with ACS. Their past medical history includes rheumatoid arthritis, for which they take slow-release morphine sulfate 10 milligrams twice a day to help control the associated pain. Your F2 colleague has charted this drug history medication as follows. Can you spot the mistake? Let me try and make it a bit bigger. So what is the mistake in this? In this prescription? What's wrong with that? Someone's going to have to write it out in the chat box or put their microphone on. Nobody knows? No one can spot that error? Anyone want to guess? Okay. Would you want to use fast release while they are in hospital because you can monitor and reverse if needed? Not exactly. So the prescription he should have written up was morphine sulfate, 10 milligrams twice a day, slow release. So nowhere in this prescription has he written modified release or slow release. So that would be the mistake. The prescription needs to state MR or modified release. Because if it doesn't state modified release, then they will just be given an instant release tablet. And so with modified release tablets, if this is given every 12 hours, it releases a certain amount of pain relief every hour for 12 hours. But if you give an instant release, you get a massive whack of pain relief in an hour, and then then it doesn't adequately control the pain for the rest of the 11 hours. And so it's important that you put MR, otherwise they'll just receive the wrong drug, if that makes sense. Yeah. Okay, so the next one is the same patient is also on methotrexate 15 milligrams once weekly for their rheumatoid arthritis. Your F2 colleague has charted this as follows. Can you spot the mistake? So what's the wrong with this prescription? Your F2 colleague has prescribed it, the methotrexate. Yes, exactly. So F2s can't prescribe methotrexate. Like I said, in the medicines policy, it states that junior doctors aren't allowed to prescribe immunosuppressants. And this is because immunosuppressants can be particularly dangerous if prescribed incorrectly or inappropriately. And so anyone with a more senior doctor, so a CT1 or above, can prescribe these medications. Okay, so upon discharge, the patient requires a 2-week supply of their drug history medication, including the morphine sulfate modified release 10 milligrams twice a day. The TTO is complete as below. Is there anything missing from the prescription? The patient details are present and correct, although not shown here. Anyone know what's wrong with that prescription? No? Okay, again, the correct formulation is not specified, so you need to put that modified release tablets. And this is just really, really important, because if you don't write it, then they won't get it and their pain relief won't be controlled, and then you'll get a complaint and they'll come back into hospital stating that their pain is not controlled. So whenever you're prescribing pain relief, you need to put the correct formulation. So this is another one. The prescriber realizes their mistake and updates the TTO as below. Is there anything else missing from the new prescription? Is there anything missing from it? Okay, let's go through it. Prescription is not signed, so it's a legal requirement for any prescription to be signed. So if you don't sign something, then it won't be dispensed in the pharmacy, and then the patient will be left without medication. So it's really important that you sign all of your prescriptions. So a patient is admitted with a mild case of cellulitis. They state that they get a rash with penicillins, and therefore, as per Trust antimicrobial guidelines, the most suitable choice is doxycycline 200 milligrams stat dose, followed by 100 milligrams thereafter for a total of 7 days. The stat dose has been prescribed correctly on the front page. What is wrong with the prescription for the rest of the course? Okay, this is quite specific to LGT drug charts. It's just been prescribed on the incorrect section of the drug chart. So it should be putting on the antimicrobials part of the drug chart. So the prescription is crossed through and re-prescribed on the antimicrobial section. Can you now spot the mistake? Get it a bit bigger for you. Anyone know what the mistake is? Okay, so the date of the stat dose has not been crossed off the drug chart. So you need to put that X, otherwise they'll get a double dose. They'll get their stat dose and then they'll get the dose that is written on here. It's really important that you don't put those, you cross off the stat doses to make sure, avoid duplication of doses. Again, you should have been emailed these prescribing exercises, but you haven't, so you won't really be able to do them. So I suggest when you are emailed them, then you have a go at it, and then I'll send around this presentation so then you can go through the answers to make sure you got the same ones. And if you don't, then feel free to email me. We can go. That sizes that would be on that email. So again, yeah, you can go through it, and then I'll email this round, or hopefully you'll get it, and then we can go through it or you can go through it, and then if you don't understand anything or you haven't got anything that doesn't make sense, then you can drop me an email. Normally this session is a lot longer because you would have the material in front of you. It's just unfortunate that you don't. So does anyone have any questions on prescribing in general before we close this? Or anything that they're unsure of that they've seen on the ward so far? Anything in general? Do we have teaching next week? I believe you do have another session next week, and I will make sure that you get all of the pre-reading and pre-work beforehand. I'm going to try and find out what happened this week. Again, apologies. I think there must have been some sort of miscommunication. Okay. Well, I hope you enjoyed the session. Again, I will follow up on that teaching, on the material, so that you at least have a chance to do it yourselves. And if there are no other questions, then I hope you have a good day or a good rest of the day.